So I want to turn this over to our speaker today, who's a really, really important piece to share with all of us today. Victoria Tiase, or Dr. Tiase, is a nurse, informatician, and researcher. She's the Director of Research Science at the Value Institute at New York Presbyterian Hospital and is an Associate Professor in Health Informatics at Weill Cornell Medicine. She's been appointed to numerous national boards, including the National Academy of Medicine's Future of Nursing 2030 Committee. The focus of today's talk is on the future of nursing and that committee and their report. Her full bio is on the conference app, and I invite you to view that. I'm going to welcome Dr. Tiase to the stage, who is going to talk to you. Hopefully, we'll have some time for conversation or questions at the end, and then I have a few other words to pass you on to the next thing. So welcome, Dr. Tiase, and thank you very much for coming.
Terrific. Thank you, Carol, and thank you to ANAC for the invitation. I am delighted to be here. I'm also going to echo the comments. You know, being in a room finally in person with a lot of nurses, just that kindred spirit is just so powerful, and I absolutely feel it. So thank you so much for this invitation. And I'd also like to thank ANAC for recognizing the importance of this report and elevating its visibility. So I'm excited to tell you a little bit about it here today. So it was my honor and privilege to represent nursing, especially with technology and informatics expertise on this committee to craft this report. And if you'll bear with me, I'll segue for a moment, since when I speak with non-informatics audiences, I get a lot of questions about what's nursing informatics? How do I get involved in that? So I'll just give you a little bit for those that might not be familiar with it. So informatics is a nursing specialty where we look at using data and information and technology in order to impact and influence nursing practice. So this could span from what most people think about implementing EHRs, but you know, now that we are mostly electronic, it goes way beyond that. So it's how do we create new algorithms, how do we design and deploy mobile health technologies, and how do we really connect with digital transformation. And so my connection to this report actually is on the mobile health technology front. So I'll just give you a little piece of history on that. So about 10 years ago in New York City, there was the development of the New York Digital Health Accelerator program. And it was put in place with the idea to bring new companies into New York City and really build that ecosystem of digital health. And as a part of that program, I served as the mentor for my hospital and worked with mobile health companies, orienting them to the city, piloting their tools and technologies, and then also connecting them with clinicians to give them feedback about their tools. And it was interesting because at the time, my office was in Washington Heights. Due to my ability to speak Spanish, I was doing some work with clinicians in that community and getting them off of paper. And my immediate thought was, well, we need to think about piloting these tools in diverse populations. So let's bring them up here to Washington Heights. And it was interesting, some of the feedback that I received, because a lot of my colleagues and even some of the companies themselves were like, oh, well, wait a minute, maybe we should try a different population, or maybe you don't want to do that. And you know, of course, as soon as I heard that, I was like, all right, we're definitely doing this population then. So we moved forward, and we had some great learnings. Again, this was 10 years ago, so it was when mobile health apps were in their infancy. And we found that our, Washington Heights populations absolutely wanted to use mobile health apps. However, we have to make sure that when they're designed and implemented, that we are thinking about equity, that we are thinking about different languages, that we are thinking about the cultural implications. So from there, I was really interested in this space and figuring out how we could ensure that all technology is thinking about health equity. I'd also like to give a quick shout out to someone that you may know from your community. So I also collaborate closely with Dr. Rebecca Schnall, who worked on tools and the usability amongst persons living with HIV in our Washington Heights community. So she has been a tremendous resource to me, and I think we have a lot of work to continue to do in this area. So thank you for allowing me to do that little segue. So now back to the report. So over 500 pages. So anybody here take a look at the report? Show of hands, anyone? Some light nighttime reading? Okay, great, thank you. So it is a lot. So it's 11 chapters, 9 recommendations, and there are actually 54 sub-recommendations. So it is a lot to digest. I won't be able to get through all of it today. However, my plan for this next 45 minutes or so is to provide an overview of 4 of the main key messages in the report, and go over some of the recommendations for each of them. And then also, which aligns nicely with your conference theme, think about some of the actions that we can take moving forward. And at the end, hopefully allow some time for some discussion and comments, open to your thoughts on how we can move some of this work forward. All right. So, why health equity? So this is a sad fact here that we spend a lot of money in this country, right? So for way too long, we have overinvested in treating illness, and we really have underinvested in the promoting the health and well-being and the wellness components. So this is a real issue. And despite all of these financial investments, there are still significant issues around life expectancy, infant mortality, now maternal mortality, which we see getting quite a bit of press, all of those worse in the United States. So we are lagging behind other countries. And while COVID has really illuminated some of these health disparities, truth be told, they've been around for much longer, so well in place. So it's quite coincidental that this report was actually crafted and the statement of task was put together in 2018, so long before we saw COVID, and we were very lucky to have an extra 6 months as a committee, so we were funded for an extra 6 months so that we could include some of the COVID components, especially around pandemic preparedness for our nurses. All right, so a little bit of history. So for those that might have been around for the first report, how about anyone read the first report? Maybe a little more of those, because I know some schools have had that as required readings. But so this first report was crafted dreamed up in 2009. So at the time, Robert Wood Johnson Foundation approached what was then called the IOM. So now the IOM is called the National Academy of Medicine. But back then, being the IOM, they wanted to put together a report to think about how to build the nursing workforce. So for those of you that might have seen that first report or seen the findings, that all connected to increasing the number of BSNs, accelerating advanced degree nurses, and really thinking about how we could understand the diversity of the nursing workforce as well. So there's a little bit in that first report. Really not much in terms of technical items, so that was interesting from my perspective. And then the biggest thing out of that first report, which we are still struggling with today, is thinking about full full practice authority. And I know I saw on your website with one of your position statements, you had one come out on full practice authority even before this first report was crafted. So kudos to ANAC for that. But now, fast forward in 2018, the Robert Wood Johnson Foundation again approached NAM and said, okay, first report is over. We'd like to get the second report up and running, but we don't want it to be a part 2. And we want it to be very intentional about thinking about health equity. And thinking about the fact that nurses are well positioned to support health equity and create that healthy future for all. So the report was released this past May. It is also available as a free PDF download on the NAM website, so you can access that if you'd like. But again, the idea here was to make the case that nurses need support and resources and need to be prepared in order to move health equity forward. Okay, well, the big focus of the report in terms of data is thinking about the social determinants of health. So we know this quite well as nurses, that race, ethnicity, the sexual orientation, immigration status, health access to care, the type of health insurance, or if you have health insurance, all impact whether we will experience preventable or costly medical conditions. So understanding the roots of these inequities and understanding our patients at an individual level in terms of, do they have housing? What's their transportation like? And what kind of job that they have, green spaces in their neighborhood. So all of these items will help us improve an individual's well-being. So one of the things is having the data and information for nurses to support these types of decisions. The next key area of the report is focused on racism. So again, we did this work long before the Black Lives Matter movement and the experiences of 2020. But we are very fortunate to have Dr. David Williams as our co-chair to really walk us through some of his work around racism and how that impacts health. So racism in all its forms is a key factor in terms of how long and how well people live. So in the report, we focus on 3 types. So the structural racism, so that's around the processes that we have in our laws and policies and our practices in society. Cultural racism, so that's the ideology piece, values and language of our larger society. And then lastly is discrimination. And certainly this impacts our nursing community. So in the nursing community, discrimination and dehumanizing attitudes are omnipresent. We still have issues with bullying reported. Black nurses have long reported encountering racism at work and within nursing school. And from my personal experience in New York City, during 2020, or during the spring of 2020, we had a number of our Asian nurses at one of our regional hospitals have their tires slashed during an overnight shift. So we have a lot of work to do in this area, and we wanted to make sure that this was reflected in the report and that it took center stage. So social determinants of health and racism. And just a quick call out to the committee here. So we had, as I mentioned, Dr. David Williams and Dr. Mary Wakefield serve as our co-chairs. And you can see we had 15 experts in nursing leadership, but also in public health, in workforce, in education. As part of our 2.5-year process, we had multiple town halls. So they took place in Chicago, Philadelphia, and Seattle. And that was a great opportunity for the committee to hear from different nurses in different parts of the country, from different organizations. They were all provided the opportunity to give testimony. And we also did a number of site visits, so had a number of great ways to get information to contribute to this report. And then in accordance with NAM policies, since I do get some questions around this, we had to use existing literature and evidence in the field. So although we could take the private, or I should say the testimonies from the town halls into account, we could not use personal use cases, or we could not use some of the anecdotal findings. And I think this was really, for me, quite eye-opening from a technology perspective, because I recognize that there are a lot of great stories and a lot of great work that we're all doing, but it's not always published. So I think that is something to think about, and we actually mentioned that as one of our report findings towards the end. So this is what got us to crafting the report and the recommendations. And then we had fantastic support from the staff at the NAM, and as I mentioned, they really allowed us the opportunity to include the pieces on COVID, which we thought was super important. So now, the first activity as the committee was crafting this vision you see here. So certainly we wanted to make sure that strengthened nursing capacity and expertise were threaded throughout all chapters. So this reason is simple. We feel that nurses are everywhere, in all settings and at all levels. They're in clinics, they're in ICUs, they're at the sites of disasters. And we're the largest and most trusted segment of the nursing workforce. And we are well suited to help advance health equity in this country. Serving as bridge builders and collaborators. I think the important piece is that this isn't about nursing doing this alone. This is about nursing leading the effort and bringing in our interprofessional colleagues, which again, I think nurses are skilled at that as well. And then, one interesting example here around this vision is that when we were in Chicago, we found some nurses at Rush University Medical Center, and they were actually pulling together, and you've probably heard numerous stories around this, pulling together leftover food at the hospital and delivering it to the community. So there are a number of great examples like this, which I will cover. It's a little scary. Okay, however, in order to do this work, nurses need support from the systems that educate, pay, and employ nurses to enable nursing to continue this critical work. So across the board, we truly need to ensure that nurses are valued, and these are the 4 key actions that the report lays out. So I'll walk through each of these in detail today. So it's about permanently removing barriers, and that's related to scope of practice. How do we value and even quantify nurses' contributions? And how do we prepare nurses to advance equity? So that's really connected to education. And then lastly, but I think most important, continuing to diversify the workforce. So to start, I'll talk about how we can permanently remove barriers that stand in the way of nurses in all areas and in all settings. So there are a number of barriers that are faced on a regular basis. So everyone, no matter where they live or what they do, should have the opportunity to have high quality access to affordable health care so they can be healthy and well. But more than 80 million people, so roughly 1/4 of the country, which is kind of crazy to think about, live in an area with a shortage of health professionals. And by 2033, the current physician shortages will increase, especially in the areas of primary care. So this is going to be big, especially in our rural areas as well. So thinking about how we are going to fill this critical gap is important. And we need to ensure that our nurses are given the autonomy and the institutional support to do this. So in there lies two major barriers. So one is expanding the scope of practice. So this can be lifted through policy changes. And then also institutional ones where nurses are working, learning, and training. So to start, let's look at scope of practice. So this refers to what a healthcare provider is allowed to do for the patient. So keeping in mind their education and training and, of course, the type of license that they have. But the report looks extensively at what it means for APRNs, which includes nurse practitioners. So expanding the scope of practice for APRNs allows them to prescribe medication, diagnose patients, and really treat patients without the oversight of a physician. However, the issue is that although nurse practitioners absolutely have the education and training, they do not have this level of autonomy across our country. So considering this severe physician shortage we are experiencing, expanding the scope of practice for nurse practitioners seems to be a no-brainer. And here, this is quite amazing, and I actually did not recognize the extent of this until I became a part of this committee. So the evidence also shows that in addition to creating more access, restrictions for NPs also contribute to higher costs. And in fact, during the pandemic, 8 states expanded the scope of practice so more could access care. However, as you can see from this map, we still have 27 states, so more than half of the country still restricts full practice authority, so half of the country. So in 16 states, nurse practitioners need physicians' authority to prescribe meds, and 11 states, they require oversight for all of their practice. So 11 states, so absolutely a lot of work to do here. So here's a nice example of how expanding scope of practice optimizes care. So in 2017, to address the opioid crisis, a federal waiver allowed nurse practitioners and PAs to prescribe buprenorphine, and a move that significantly increased access to care in some of the rural areas, and kept many people who were experiencing addiction safe in those places. So until APRNs can practice to the full extent of their education and authority, examples like this can't happen in all of our states, and these preventable gaps in care will continue. The other big barrier is from an institutional perspective. So even though a state might allow full practice authority, there could potentially be institutional barriers put in place. So this ranges from restrictions on providing telehealth services to workplace policies that prevent them from giving optimal care. So these institutional barriers can also start in schools. So students from underrepresented backgrounds, people of color, those with low incomes, first-generation college students, LGBTQ students may need support in a number of areas as they go through nursing school. So they might face financial barriers. So well before the pandemic, many of the 4 million nurses also had mental health issues. We're seeing it highlighted now, but again, this is not new. So organizations that employ nurses don't always give them the support that's needed. So we have a number of issues in the institutional space and the institutional structures that need to be broken down. So one example from COVID that I just mentioned briefly was telehealth. So before the pandemic, many nurses were not allowed to bill for telehealth. But during the pandemic, CMS lifted some of those restrictions. And nurse practitioners were able to screen patients for COVID-19 and treat other non-critical issues via telehealth. It also helped to maintain a robust workforce, because NPs that might have been quarantined could actually see patients from home. So there's a lot of value to lifting the restrictions around telehealth. However, we have already started to see some of these policies reversed, even though we have noticed the improvements. So truly thinking about how we can, this one is front of mind for me, how we can get the evidence out there quickly and work with our policymakers in order to turn that around. So here are the recommendations related to this first key message of the report. So to address these barriers, the report recommends policymakers expand the scope of practice. And federal authority should be used to supersede some of the restrictive state laws. By 2020, all related changes in policies adopted in response to COVID should be made permanent. So again, we've seen that they work. Employers and government agencies removing institutional barriers, such as restrictive workplace policies. So the evidence shows that these actions will help expand and improve access to care in communities across the United States. All right, moving on to the second key message. So how can we better value nurses' contributions? And moreover, how can we measure it to ensure we're advancing health equity? So as the committee found, the current system does not value addressing social determinants of health, nor advancing health equity. And that certainly connects to money, reimbursement, right? So that's what we're talking about here. So we did not see that. It's designed to pay for quantity and not quality. We can treat existing illnesses, but not prevent them. So how do we prioritize preventative care over primary care? So this model that we currently have has really deepened disparities and disproportionately impacted people of color, those with lower incomes, LGBTQ community, et cetera. Those in rural areas have really taken a hit, as we have seen. So certainly this value piece cannot be underscored. But nurses can help change this. So as that largest and most trusted profession, we can bring value to our communities. And I think you all know this quite well from the communities that you serve. But without this strong financial support, the reach is limited. So how care is paid for can determine one's access to the level of their quality of care. So we have two key actions noted in the report in order to achieve this goal. One is reforming our payment models, and the other is valuing community and public health nursing. So as mentioned, the current system prioritizes volume of care and underestimates the value. So this work is under-recognized and undervalued, and we can see it in the reimbursement. So in the reimbursement of physician services, that the APRNs are reimbursed at 80 to 85% compared to the full reimbursement that physicians receive, right? So 80 to 85% of the 100% that physicians would receive. In 2014, the federal government rescinded a policy that prevented school nurses from billing Medicaid. However, even though that policy was rescinded, the ability to bill is still very complicated and difficult for the school nurses to complete. And in 2019, 7 states had made changes. So we still have some work to do there, since there are only 7 states. But I think there's some opportunity for us to move that forward. And I would also say the second piece related to this that we cover in the report is something called a National Nurse Identifier. So if we want to quantify the value of these school nurses, the value of all nurses, we need to have a way to identify all of our nurses throughout the country. The next piece connected to this is in the events in this past year, we realized that getting out into the communities is so important, and our school nurses play a vital role. But as you can see here, 1 in 4 U.S. schools do not employ a school nurse. And the committee found also, in some cases, the school nurses were covering 2 to 3 schools at a time. So I even think that this does not accurately reflect the lack of school nurses that we have. So by having school nurses, we can support some of the mental health issues, which we know was actually a third of what school nurses were doing before the pandemic. So again, we are already seeing this increase, and this is going to be an important piece. Our school nursing associations are already moving this forward, but I think this is something that our whole entire nursing workforce can get behind. And this is a really staggering statistic here. So we found this in a study in Massachusetts, that every dollar invested in school health services yielded $2.20 savings per student in avoided medical procedures and in lost productivity of teachers and parents. So it shows that money invested in school health services can absolutely recap real monetary benefits. And one more example here, I wanted to highlight the work of Robin Coogan, who is a school nurse in Camden, New Jersey. So the committee had the opportunity to visit Camden and understand the close connections that are going on with the community there. So she has been a long-term advocate for connecting with the community and finding out what parents need. She started community cafes. And what that consisted of is meeting with parents in the community over coffee and understanding the challenges that they're facing, so she could support the students that she was seeing in schools. So these conversations have led to conversations around the immigrant experience, the father's role in students' lives, and she has truly done reform work to foster healthier communities. So thinking about how more school nurses could participate in these activities if we had them in all schools. So in terms of the recommendations in the report connected to this key message. So to better value nurses in all levels, it's going to take sustainable and flexible payment models and figuring out how we can provide research and provide evidence is going to be important to support that. And we feel that this includes ramping up our school nurse workforce and thinking about how nurses can bill for telehealth services, so get that back up and running for places that have pulled back in those areas, and centering performance measures around quality and not quantity. So I know we've started down the path of value-based care, but we are not there yet. And I think as nurses, thinking about how we can advance that further. And then last but not least is ensuring that we are funding and supporting our public health nursing workforce. We are very excited to see that there is already federal funding earmarked to set up a public health infrastructure. So I know we are eagerly awaiting to see how nurses can take advantage of that and where we can move that forward. All right. Item number 3, or key message number 3 here. So the report's central theme, as I mentioned at the onset, is carving a path to health equity. So how can we better prepare nurses to do this? So the truth is that all nurses in all settings are not fully prepared to advance health equity. So thinking about health and social needs, economic needs in their community should all take a number of forms. So the report covers 3 main areas that we can do to prepare nurses. So one is transforming our nursing education. And the report dedicates an entire chapter to this. It's one of our lengthiest chapters. Also preparing nurses to respond to disasters and public health emergencies. So this was actually a new chapter that was added in our extra 6 months for COVID. We thought this was important to have a specific chapter on public health emergencies. We also found this as an issue that was loud and clear amongst our National Student Nurses Association. So we heard from the president of the National Student Nurses Association, and she said that thinking about disasters and how nurses can respond in hurricanes, in floods, tornadoes is going to be an increasing issue with climate change, and urged us to include it in the report. And then the last piece, but certainly not least, fostering nurse well-being. We actually had some major deliberation as a committee as to if we should have well-being as the first chapter or the last chapter. It is our last chapter of the report, and we hope that that will serve as a lasting impression for those reading it, that well-being is something that we need to take seriously. Okay, so the pandemic has really reinforced our need to ensure that nurses have a deep understanding of the social, economic, and the environmental factors, so the social determinants of health, racism, and health equity. But what we found is that nurses are not being taught this in the classroom. We have found in some cases that nursing schools will cover it, but it'll be in a siloed class off by itself, and it's not integrated throughout the curriculum. And in some cases, we even found it as an elective, where it wasn't even a part of the main curricula. So this is a real issue to solve. There's also a significant shortage of faculty that can teach these types of classes. So this plays a role in potentially turning away applicants that might be looking for that in the curriculum. But we can change this. So nursing education programs, universities, we need our creditors on board for this. Also thinking about the NCLEX. Since we know a lot of schools teach to the NCLEX, and if it's not there, they might not have the content within their schools. So we also need to collaborate with the state boards of nursing to strengthen the curricula and ensure that nurses are also getting that practice experience in the community. So that's another piece that we found missing. So the report thinks that this is another area to stress. So a couple nice examples that we included in the report and that we found in our evidence. So this one here is a program in Topeka, Kansas. So they partnered with, the school partnered with the Topeka Housing Authority, and they opened up a family health center. And with this family health center, you know, they are catering to those with lower incomes that have limited access to care. And through this, it's an educational forum for students. So students are placed as part of their practicum experiences in this health center, and gives them that real-world experience in addressing social factors. So we thought this was a terrific use case that we would love to see more of. They also cover a lot around social justice and trauma-informed care, so a lot of great pieces. And here's another example. So this is at University of Texas, San Antonio, School of Nursing. So they view and promote that health and health care is an act of social justice. So here, the students, and many of which come from the community, give back during their experience in school. So the School of Nursing's dean is absolutely incredible, so it really comes from the top, has support from the university officials, and with a HRSA grant, they opened up a managed health center. And they have interprofessional healthcare students, so not just nurses, but it happens to be led by the School of Nursing. They also formed a partnership with the largest Medicaid managed care plan in the state, and are able to really give students that community level experience while supporting care in the community at the same time. And I think the interesting factor here is that they also base faculty promotion and tenure not just on their scholarship and research, but also on their involvement in the community. So that's why we saw this as a great use case, that the faculty are incentivized to do this type of work, and the students are all the better for it. And the next piece here is around the preparedness chapter that I mentioned. So obviously the past, shouldn't even really say year anymore, we're going 20 months, has illuminated the impact of national disasters and public health emergencies, and how our nurses are not as prepared as they need to be. We know that nurses are serving on the front lines of these emergencies, and also that public health emergencies do disproportionately impact those of color with lower incomes, those experiencing housing insecurity, and those with limited access to care and transportation. So this is an amazing intersection of equity. But as mentioned, our nursing education systems do not prepare nurses to do this work, especially through an equity lens. So it's one thing to prepare nurses to respond to emergencies, another to ensure that's with an equity lens. So the report advocates for both. Again, this goes to curricula, ensuring that nursing programs are thoroughly teaching about emergency preparedness, climate change, threats to global health. So a lot of pieces here that we see are missing from the curricula. And I think most recently, thinking about emerging infectious diseases, vaccine hesitancy. So all of these receive very minimal coverage in our nursing curricula. And nurses who have learned about these topics have reported low confidence in responding to public health emergencies. So again, absolutely more work to be done here. And then the last piece around our public health, again, also includes our school nurses, can help with community engagement activities like disaster planning. Community emergency response teams have been formed in some areas, helping families compile their own disaster preparedness kits. So how can nurses get involved in these activities? And I think, again, nurses are well suited for this. So this is where nurses can use their non-clinical skills, if you will. So networking, communication, connecting interpersonally. So connecting this with an understanding of SDOH can certainly mitigate our potential ongoing issues with natural disasters. So the systems where nurses learn and work need to do more to support well-being. So as the COVID-19 pandemic has starkly revealed, responding to a crisis takes a serious toll on nurses. Also, our work in health equity does as well. So these are all very challenging areas that affects the well-being of our nurses. And I know some of you probably know these statistics quite well. So the estimated rates of burnout range from 30 to 45%. Nurses are at a higher risk of suicide than the general population. There's an expected culture within nursing that still permits hazing, bullying, intimidation, hostility. Nurses that work in our long-term care facilities are experiencing stressors such as verbal and physical abuse. And then, as we know, nurses are not always given the resources they need to do their jobs. So with all of this in mind, the well-being of nurses needs to take center stage. And the committee felt very strongly that this is not about nurses being more resilient. This is about how do we fix this at a systemic level. So some universities have started to take a stab at this. Yes, my alma mater. Do I see some who's in the audience? Awesome. Great. So we took a close look at this compassionate care initiative, and we were very impressed with the work that's done here. So at the nursing school level, so before they get into the nursing workforce, they have focused coursework, workshops, retreats, meditation, yoga classes. They also conduct research on things like compassion and resilience and self-care. They also have an ambassador program, which actually has students and faculty working with community members to understand the successes and challenges in moving this program forward. So we think this is a fantastic use case and a great example in this area. In addition, as you may have seen, a lot of associations and other professional organizations are also taking some major steps to support well-being. The Pathways to Excellence program, so the Magnet program, is now looking at recognizing healthcare organizations that demonstrate a culture to promote well-being in the work environment. In May of 2020, you may have seen that the ANA Foundation, the philanthropic arm of ANA, put together a huge well-being initiative for nurses. They've got a great website with a ton of resources that nurses can take a look at. There's peer-to-peer conversations, which I've heard anecdotally. People have really gotten a lot out of those. There's hotlines, cognitive processing techniques, and they also have some free apps for stress reduction, so a lot of great work by the ANA. And then another piece we saw, the National Black Nurses Association has an NBNA affirmations page, a place where nurses can share favorite quotes or positive affirmations with one another. So nurses supporting nurses. So I think it's great to see these organizations taking the lead, and we hope more will follow. So in terms of action steps for this key message, so as mentioned, getting the nursing education programs on board so that they are strengthening the curricula in these areas and reviewing it regularly. We would also like to see federal agencies, employees, nursing schools, and other stakeholders strengthening that response to public health emergencies. And also calling out the CDC to establish a national center for disaster nursing. We think that is critical in order to achieve some of these efforts, and will be a way to act as a hub to prepare for the nursing workforce. And then, last but not least, ensuring that we are supporting nurses in every way possible so that they can support the well-being of others. And that is really, we feel, falls on the employers. We really need our healthcare organizations to take a close look at this. In addition, we urge nursing schools to commit to dismantling racism within their own institutions. So again, changing curricula, which have historically focused on the contributions of white and female nurses. So how can we change that? Having those difficult conversations around privilege and power, and again, ensuring we have the faculty that know how to work those conversations. Dismantling our long-standing exclusionary traditions, understanding how racism shapes the student experience, We don't have a lot of research in the student area, so I think this is a potential area of great work. And then reviewing and detecting biases in the curricula on a routine basis. So that connects to what I said earlier about ensuring that it's a part of accreditation. All right, the final action I'll cover today is the urgency of diversifying our nursing workforce. So here we have some data on our nurse practitioners. But when we discuss diversity, we mean diversity in all of its forms, right? So this means race, gender, ethnicity, sexual orientation, geography, and many more. So it's not looking at just one piece. So over the past few decades, the nursing workforce actually has grown steadily diverse. But let's face it, it is still a very white and very female profession, which we have to figure out how to change that. But progress is worth noting, as you can see here. So the nurse practitioner workforce has become more racially diverse since 2008. But again, despite this progress, we still have a long way to go. Also, this connects to ensuring we have proper measurements. So again, we have little data on our students, our nursing students, and as you can see here, this is specific to nurse practitioners. So continuing to get our baseline data and make meaningful progress. Here you can see that our latest data shows that the racial and ethnic minorities account for 40% of the population, but only 20% of our workforce. You know, so why is this? And in the report, we lay out a couple of suspected reasons. So there are still significant cost, cultural, social, and just general awareness barriers that prevent people of color, those with low incomes, first-generation college students, and others from pursuing careers in our field. And particularly, it deters the pursuit of advanced degrees. So not just becoming nurses, but then getting advanced degrees as well. And one of the issues is nursing programs and their faculty are overwhelmingly white and female. So 90% of all nurses in formal leadership positions are in fact white. And again, as mentioned, these faculty are not prepared to educate students about SDOH and health equity. So anyone in the audience from Rhode Island? This is one of my, all right, great. This is one of my most favorite examples from the report. I think it amazingly impressive. So I think preparing students or introducing them to nursing before college is going to be important to create that pipeline. So here at the Rhode Island Nurses Institute Middle College Charter School in Providence is an amazing example. So it was launched in 2011. And their first class graduated just in 2014, so graduated from high school. So it's provides a 4-year nursing-focused high school free of charge to any student in Rhode Island. So they graduate high school with real-world experience and up to 20 college credits. So gets them going, and also they have a connection with any Rhode Island public college or university. So this is pretty amazing. It has impacted the diversity of the nursing pipeline in Rhode Island in just a short period of time. So about half of the program's participants are Latin and 1/3 are Black, and they come from low-income, underserved communities. So this is an affordable, direct path into nursing. So if we could see this in all of our states, imagine the impact that could have on our profession across the country and for the people we serve. Another one here, this is at the University of Cincinnati. So this is for underrepresented or first-generation students in bridging high school to college. So they have this summer bridge program to help them continue on and actually go to college. And we saw that as a huge bonus because they do also support nursing students as well. So although it's not nursing specific, we think that is also a nice example that could be replicated across other states. And in addition, at the University of North Dakota, they have something called RAIN. It provides a no excuses orientation workshop for American Indian students to connect and participate in discussions about moving forward in their schoolwork and staying connected to their communities. So again, thinking about how do we tell these stories and see more examples across the country where appropriate. So for this last key area, the report recommends that if we want to diversify the nursing workforce, nursing schools have to be intentional about recruiting, supporting, and mentoring both faculty and students. So we need both from diverse backgrounds to ensure that the next generation of our nursing workforce really reflects the diversity of the communities that they serve. And we feel, again, nursing accreditors can play an important role by requiring standards for student diversity, just like other health professions and schools. So interestingly enough, if you look at other health professions, they do have diversity requirements. Nursing schools do not at this time. So this is an interesting area to explore further. So now, what can we do? So the systems that educate, pay, employ, and enable nurses have a lot to do to support health equity for all. However, there certainly are activities going on within our nursing organizations that we think can continue. So the trick here is that there is great work in the individual organizations, but the barrier we face is that not all of our nursing organizations are working together. So one of the huge recommendations in the report is about a shared agenda. So how can we have individual nursing organizations doing work, and combining all of our organizations for a larger agenda, leveraging our 4 million strong power. So I'll quickly review a couple of examples here. So one that we found is the Community Action Poverty Simulator. So this is some super interesting work, having students take on the roles of individuals who are facing challenging but typical circumstances for those in poverty. So really breaking down those stereotypes and understanding the experiences. Another one here is called Mind, Body, Strong. So this is work that's skill building for nurses in their practice. So this is for supporting nurses as soon as they are hired. So it's 8 weekly sessions focused on caring for the mind and building skills. So a lot of times nurses leave school, head into practice, and are sometimes alone and unsupported. So I think this is, again, a nice bridge to connect the dots there. And then nurses at all levels and all settings can advocate for equity in their communities. And I think this is where ANAC has some tremendous experience. So again, your website has some great position statements from scope of practice to strengthening equity in research, and a health disparities statement that was crafted in 2009. So again, way ahead of its time from this report's perspective. And there are a few other examples. We have 2 nurses in Baton Rouge who have connected with the community to address food insecurity and isolation, especially over the last 20 months. And the other group that we met with is in Washington State. They're called WOW, the Women of Washington. So it's a group of nurse leaders who are positioned strategically by the governor in specific areas, in housing boards, leading the Medicaid for the state. So really amazing. And these nurses get together and figure out shared agendas to advance health equity within the state of Washington. So really, again, really great example that we would love to see replicated. So hopefully today's conversation has given some food for thought on how we can collectively chart a path over the next decade. And I think, again, this is multidisciplinary with nurses leading. And I think the other area is connecting with our international colleagues as well, learning from what's working in other countries. So as a final thought, so this report, as I mentioned, synthesizes the evidence and provides recommendations, but now it's time for the collective us to take it and run with it. So there's a piece for all of us to take action and advance advocacy. So please keep an eye out for ways to stay connected. The NAM Future of Nursing website has a number of webinars. The Campaign for Action in your individual state is also a good place to start. They have already gotten some action plans up and running. And I think this is just the beginning of a new decade for nursing. So if we learned anything in the last 20 months, it's that the nursing voice is being heard. Now we have to put those voices together and figure out how to use it to enact real change. So I know this is a lot to cover in a short period of time, but hopefully it serves as some inspiration for us all to keep going and to keep advancing health equity. So thanks for your time, and please feel free to reach out to me if you have interest. So I think, unfortunately, we just have a little bit of time for questions. Yes?
Yeah, we could have a question, if someone has a question.
A question?
That's where we are with time right now.
Yes, please.
Hi, I'm Jim from the Palm Springs chapter. It's more some comments, I guess. Like you said, we're 4 million strong nurses, but that's just the RNs that they're counting. What about the availability and the help of our LPNs and our LVNs in our communities? We have that team nursing aspect. I don't know how many people work in a hospital that actually uses team nursing. So our LVNs can really, or our LPNs can really play a role in helping some of that burden. You had mentioned the faculty shortage. I am a faculty member, but I have said that we are requiring so many initials behind our name to teach that we're creating this shortage. Why does a community college professor need a master's degree to lecture an associate's degree program? I mean, I think we need to look at the reality of what's happening right now. And as the disparities in education, why do we have primarily white females in these leaderships or as a faculty member? I completed both my master's and my bachelor's without one male professor. I mean, that says a lot right there.
Yep.
You mentioned money. There's no money in prevention. Let's think about that. If I prevent the disease, where's the worst pharmaceutical going to get their money? Sorry, Gilead. I mean, it's, and you talked about barriers to practice. As an ER nurse, critical care nurse, I remember the days where I would have an order that would say Norco 1 to 2 for pain. Now they can't do that. It has to say hydrocodone acetaminophen 5 milligrams for pain of 3 to 5. Nurses are not allowed to critically think anymore. But what sucks is the NCLEX, the next generation of NCLEX, is actually requiring students to critically think even more. Yet when they get to the bedside, that's taken away. So where is our scope of practice? We are such a powerful workforce. Look what happened when we were forced to reuse PPE. We went to the streets, okay? Yep. You also mentioned pathways and magnet. So I'm sorry, but this is really...
No, one more question. We can talk more later.
Administration has to buy into pathways and magnet, though.
Agree.
Yes.
And
thank you.
California BRN, Jim. California. Yeah.
Thank you. Fantastic comments. Yeah, LPN and ADs, yeah, we have to really work that. Yes,
I know we're
please.
short on time. My name is Deborah Wafer, and I'm following up on what he says about training more nurses, and do you really need all these degrees behind your name to train nurses? And if that's really what we're trying to do, when are we going to change and do something differently? And I think the report is good. I think a lot of this information is important and important for nurses to know. But how do you guys measure it after this fantastic report? What comes next? Where do you go to see if this is actually happening and it's being instituted in the places that it needs to happen? Because poverty, lack of education, and lack of health care is not anything new in this country. And it's, all of a sudden everybody's experiencing health equity. People have been suffering this since the beginning of time. And so when do we stop writing reports and start instituting some changes?
Yes, thank you very much for those comments. I think you're absolutely right. Those are things that need to be dismantled. And, technically the report and the committee is done in a sense. So now it's on our nursing organizations to move this work forward. So I urge you, if there are things that you are passionate about, if you think there are things that are missing from the report, please put out opinion statements. Please get the word out there on what we need to do to move forward. So thank you all for your attention today, and thank you all for what you do every day. Thank you.
Thank you. Thanks. I want to thank Dr. Tiase for coming and speaking with us today, and thank you for your questions. I didn't mean to shut you down. But I do want to say California BRN, Board of Registered Nursing, California is one of the most restrictive states in our country, and it's a fight. And we're fighting against the California Medical Association, so we really have to kind of show up in all these different spaces. I don't know what it's like everywhere else, but I'm very well experienced with that state, which is very restrictive. Stopping my political statement there. I apologize that I didn't mention before, but our speaker was supposed to be Ernest Grant, who's the head of the, he's the president of the American Nurses Association, and he had, due to his schedule, he'll be on Saturday, and so I want to thank you, Dr. Tiase, for switching the schedule and coming to us early, and we really appreciate that.